Talk about myasthenia gravis. It is a chronic autoimmune disease. It is at the level of neuromuscular junction. It actually causing what? Post-synaptic transmission defect. Why? Because there are antibodies such as anti-acetylcholine receptor antibodies, anti-MuSK antibodies, anti-LRP4 antibodies. These antibodies are IgG antibodies. It bind with the postsynaptic receptor, acetylcholine receptor, and what happens? It will decrease the end the postsynaptic depolarization, which also decrease the end plate potential, which leads to defect in transmission of impulse. That leads to fragility. Okay, the weaknesses. It is not working properly. Okay, and this also reduces the number of receptors in postsynaptic neurons. Why? Because it will degrade, the lysosomal degradation will happen. Okay, so all these things leads to decrease in end plate potential, and the threshold will not reach. And what happens? It results the postsynaptic transmission defect. Okay, yes. So there are certain clinical features to it. So this is basically proximal muscle weaknesses. So the patient experience inability, difficulty combing hair, difficulty to climbing stairs. Okay, so we can talk about it on the basis of state. So the patient, the disease going through certain states. Okay, so the first thing is ocular. So it has ocular manifestation. So the ptosis will happen, and it will worsen it as the days progress. So these diseases will worsen as the day progress, and it will worsen by exercise or repetitive action, and it will improve by taking rest. Okay, that is a basic thing that differentiate myasthenia gravis from Lambert's disease, where in Lamberton disease, what happened is the weaknesses improves with time. Okay, so this is the eye. So first is ptosis, the second one is diplopia. So because it has also extraocular manifestation with normal pupil. So when we see the pupil, we can say the pupil is normal even though the patient having diplopia and ptosis. Then it can move to, yes, weaknesses. So when we ask the patient to do exercise, and after 1 minute, the proximal muscle weaknesses begin to come. But proximal muscle weaknesses, when we check the motor part like bulk, it will be normal. Um, then if we check the reflexes, that will be normal. And if we do the cranial nerve examinations, everything would be normal. So it is not neurological. It is, yes, at the level of muscles. Okay, then we should think on the 3Ds. Okay, dysphagia, dysarthria, and dyspnea. So dyspnea is the last one. When we can say the crisis of myasthenia gravis, let's talk about the dysphagia and dysarthria. So these both are bulbar involvement. Okay, so when we talk about the dysphagia, firstly, the patient difficult to swallow the solid. When the patient of myasthenia gravis is difficult to fall on the liquids, then we should think of, yeah, it is moving to its crisis level. When a patient increase dyspnea, tachypnea, orthopnea, and all the things for the pulmonary congestions, and so that time we should think of, okay, the patient is going for respiratory issues. Okay, and it also a part of the crisis. Okay, then there is something called uh, autonomic symptoms like sweating, tachycardia. Okay, so we should also think about that. See the myasthenic crisis, dyspnea, tachypnea, orthopnea, and we should ask the patient to count. So the inability to count in a single breath. Okay, bulbar. Okay, because bulbar part, what happened, it can cause for aspiration, it can leads to aspiration is the risk. Okay, then proximal muscle weakness, there will be neck drooping because there will be the weakness in neck extension, autonomic also. But what all things would be intact? Reflexes would be intact, no sensory loss, and there is no loss of consciousness or altered sense of consciousness. Okay. In myasthenia gravis, we should not use anticholinergic drugs at first. Okay. So first we need to stabilize the patient, and then only we can do medications. Okay. Yes. So what are the complications we can expect? Yes, myasthenia crisis, where we should find well then respiratory failure, then aspiration pneumonia. Okay. And the main differential diagnosis is Lambert-Eaton disease. And in Lambert-Eaton disease, two things we can confirm. Like in Lambert-Eaton disease, reflex will be reduced. Okay, in myasthenia gravis, reflex will be intact. In Lambert-Eaton disease, it will improve with time. But the main character of this myasthenia gravis is it will worse with time. It worse with repetitive action. But Lambert-Eaton disease will improve with repetitive. So the main thing is to remember is its ocular involvement, like ptosis diplopia with normal people, then proximal muscle weaknesses with reflexes intact, normal bulk, and no sensory loss. Okay, then drooping of the head, the neck. Okay, because of inability of the weakness in the extensor muscles. Then the D's, three D's, dysphagia, dysarthria, and dyspnea. Dysphagia, dysarthria, bulbar involvement. Liquid. Solid is first difficult, then liquid. Then fifth one is respiratory failure, which is very important. Dyspnea, myasthenia crisis with autonomic symptoms like anxiety, sweating, tachycardia. Okay, division diagnosis and all. Remember the three antibodies, and it is a postsynaptic transmission defect. Okay, which is relieved on rest and worsen in evening and repetition action. Investigation serology, we can find the antibodies, anti-acetylcholine receptor antibodies, which is very sensitive, 85%. Then electrophysiology we can do. In electrophysiology, we can do a single fiber EMG. We can find increase in jitter and repetitive nerve stimulation, decremental response. We can write it. Then, yeah, pharmacology. Medication pharmacological trial, neostigmine can be used. So the thing is that the first line treatment is pyridostigmine. Okay, pyridostigmine. So remember that drug name only. Pyridostigmine. It improves the neuromuscular junction transmission. The disease modifying for autoimmune corticosteroids can be used, and also acetioprine can be also used. Okay, so this is all about myasthenia gravis. This can be asked as a short note, so you can write it. Thank you.